Hello again and welcome. For those of you who have just joined, my name is Heather and I'm going to be your moderator for today's webinar. We're excited to present to you our webinar on reducing claim denials while increasing cash flow today. This is our first webinar in the Practice Improvement webinar series, so please be on the lookout for future offerings. Before we get started, there are a few housekeeping items to go over. Questions you have for us are addressed via chat message using the Q&A button at the bottom of the screen. You can submit questions throughout the presentation and they will be addressed at the end. We do also have questions for you, and those are addressed using polls. A set of polls will be conducted before the presentation. We encourage you to participate in them. Before introducing you to John McDonough, I'm going to go ahead and launch the first set of poll questions. Our first question is about how you feel each denial impacts your practice's cash flow. Please take a moment to answer for us. Thank you for taking the time to answer. It looks like everyone believes, well, 33%, the number one answer, believe that eligibility has the biggest impact on practice cash flow. And just behind that with 25%, we have coding. At this time, I'm going to go ahead and launch the second poll question on your insight into denials. Thank you again for taking the time. It looks like we have almost a 50-50 split. 54% of respondents have said yes, they feel they have good insight into denials, and 46% have said no, they do not have good insight into denials. And now that we've handled all of the housekeeping items, I'm going to go ahead and introduce you to John McDonough. John is the Chief Operations Officer and was a member of HealthPrime's executive founding team in 2004. For the past 17 years, John has provided leadership for more than 700 staff members and drives our core healthcare practice optimization operations. Prior to HealthPrime, John served in senior and executive leadership roles in a variety of companies, including Tenet Healthcare Physician Services, Triad Hospital Corporation, and HCA Physician Services. He has over 30 years of diverse experience across the healthcare industry. John is a subject matter expert in revenue cycle management, and I'm sure you will learn something of value from him today. Now, without further ado, I'm going to turn it over to John for the presentation.
Good morning, everybody. John McDonough here. Heather, just let me know if you're hearing me okay. I want to make sure that everything's working.
Yes, everything is working. We can hear you fine, and you can go ahead and share your screen at any time.
I am sharing my screen, I believe. Let me try again. There we go. That should work.
Yes, all is good now, John.
Awesome. Sorry for the housekeeping there. So again, my name is John McDonough. I'm the Chief Operating Officer with HealthPrime. I've been with HealthPrime since we started back in 2004. Part of that, I had many years experience actually working as administrator in physician practices. So I've been alongside all of you working in the trenches, running day-to-day physician practice operations. That makes HealthPrime a little different than most billing companies that you might run across, in that all of our senior management has had experience working in physician practices. So we take a totally different approach to how we manage revenue cycle than you might find from others that are in this space. So having said that, I'll go ahead and get started here with the denial prevention strategies. And everything we do is analytics driven. We want to be able to share data and then respond to that data so that we give you the best insights, and that if there's opportunities to improve, which we always find there are, we work together to enact those improvements. So having said that, Health Prime Business Intelligence helps answer 4 critical questions about your financial health. And to support these answers, we focus on 4 data tracks to give you a complete picture. So first of all, how are we doing? We support that with key performance indicators, KPI. Second of all, where are we headed? We support that with predictive modeling to show us, based on what we see today, here's how we will end up, or here's how we're going to end the year, here's how we're going to compare to last year, or how we're going to compare to expectations or budget. Next, what is the story? Our business intelligence needs to be able to drill down so that you can get to the story, get down to the detail without having to do a lot of extra work by logging into the practice management system and then running reports just to see what's going on. You'll be able to see that demoed a little bit today while we focus on denials. And finally, what can I do? It's nice to have a bunch of information, but what do you do with it? And so working with our systems, working with our ops consultants and account managers, we help you devise a plan for improving, for understanding weak spots and making sure that we're taking the right approach to correcting them. Denial prevention workflow means staying ahead of the curve, and denial causes span the entire revenue cycle. Solutions have to be engineered to ascertain root causes, and we have to be able to start solutions where the problem starts. So we focus initially on patient intake and provider documentation. That's generally the practice responsibility, but we share that with you. Then we move on to pre-billing edits and audits. That's generally your RCM partner responsibility, but we need you to help with this as well when we find edits or audits that kick claims out. And then finally, denial tracking and reporting. This is a shared responsibility. We'll show you our tracking and reporting tools. And then what we do with that is the key. Working together, we can share in the reward, which is reduce denials and increase cash to the practice. So most medical billing denials are avoidable. What we see is about 5 to 10% of charges are denied, and it can be as high as 15 to 20%, just depending on the practice and what's happening in the practice along with the billing team. So if we look at the benchmarking down below, typical practices are somewhere between 5 to 15, 20%. We've seen them even higher when we first onboard new clients, so we take a look at what's been happening in their practice. Better performing practices are going to be around 4%. And then the best performing practices are going to be somewhere in the neighborhood of 1 to 3%. Generally hard to get under 1, but we have seen a couple practices do that simply because many denials cannot be controlled. There's not much you can do. You just have to be able to accept the denial, work the denial, and get the claim or the information back to the payer that they're requesting. And this is all sourced through our Datalytics tool. Currently, we've got in this tool 67 practices reporting with over 447 providers, and it's billing out over $170 million in charges in the past 12 months. So it's a very comprehensive database where we're pulling this detail against. First steps in the denials is prevention, understanding the root cause, where they originating, such as patient access and registration, insufficient documentation, coding, billing errors, and then even payer behavior comes into play, and we'll talk a little bit about that as well. And then once we understand what the causes are, how do we prioritize them so that we're working these denials the most effectively, not only to solve for the denial itself, but to be able to prevent that denial from happening again. It's not enough in our playbook just to work denials. You need to work them with a purpose, and the purpose should be to understand why they're being denied, what's happening, what errors are happening, what improvements can we make, and then enact those improvements to reduce the denials as we go forward. So understanding what has the greatest impact is important in order to prioritize correctly, such as one of the physicians has more denials than another, or they're coming mostly from one or two of our locations, or a particular service line, or a specific payer. Maybe it's a certain CPT code that we're getting more denials on than others, maybe associated, for example, with authorizations or medical necessity, and then a process redesign. So again, looking at our data, what we're seeing is that denial causes, as we said, span the entire revenue cycle, although a large percentage are associated with front-end processes. So we're here to work with you guys not only on how as we, as your billing partner, can give you information to help improve, but how can we be a partner to you in enacting those solutions. What we never want to be are the folks that point fingers and say, well, if you just would do this better, then everything would be fine. We know that we need to work together in order to make things better. And part of that is making sure you understand the data and we can guide you as to the strategies and tactics which are going to be the best deployed to solve problems. So in taking a look at types of denials that we're getting related to front-end processes, authorizations, billing issues, credentialing, eligibility, plan benefits, all those in the dark outline, generally associated with things that we can be working on improving at the patient registration process. In the kind of teal coloring, we've got denials generally associated with physician behavior, such as coding and ability to give proper medical necessity diagnoses to support the service that was rendered. Beyond that, we've got the number one cause for back-end denials are duplicates. We see that way too often. There should not be any duplicate claims, but they do fall through the cracks. And when we see that happening, we need to make sure we've initiated processes on our end to stop that, because every claim that goes out should be either an original claim or a corrected claim. And to the extent that we're sending duplicates, we're either just delaying the process longer by not sending that corrected information, or we're just bombarding the payer with information that's not going to help us get your claims paid. Timely filing is up there in orange simply because that's really shared, right? Timely filing could be the provider turned in charges late. We see this often when the providers are outside of the office. They're working in nursing homes, doing rounding at the hospital, those types of ambulatory surgery centers, for example, where they have to bring charges back to the office so that you guys can send them to us. That can be a problem for many offices. Also, maybe they get stuck at the front desk. The physician turned in charges, but a batch wasn't scanned to us, or the fee slips for a certain day were missed, or the provider didn't close out their fee tickets from the office for a particular day and they're hanging out there without the ability to bill for those. And it could even be on our side. Maybe we got the charges and for some reason the claim wasn't dropped, it got hung up. And so we have to have constant vigilance on our side to make sure that we're not contributing to the problem. So timely filing is a shared. We have to really identify if there is a timely filing issue related to denials with the practice, then what's causing that and where do we have to put our efforts to try and resolve for that, or it could be coming in all three of those areas. So when we talk about denials, denials spanning the entire revenue cycle, we're talking about the network of pre-service, what's happening prior to the service being rendered, at the point of service, the documentation, coding, etc., and then post-service. Generally, that's going to be us, but we work with you as well, because if the claim rejects for some reason, it rejects because of an edit, it rejects because of an audit that we put in place, or eventually the payer rejects it itself in the form of a denial, then we need to work with you on getting the corrected claim out the door so that we can turn that denial into cash. So again, looking at our data, what we're seeing is that some, as I mentioned earlier, some denials are not controllable. The big ones generally here are coordination of benefits, which, as you know, are essentially delays that the payer of record has put on the claim while they work with the patient to determine, is there another insurance that should actually be the primary here? We see this, for example, with Medicare, when Medicare has reason to believe that the patient might be covered under another insurance, maybe a spouse's insurance plan from their work, for example. So they're not sure if Medicare is actually going to be primary or secondary for that particular patient. They might put a hold on it. We see that very frequently when the cause or the reason for the service is an injury, because the payer might suspect or have reason to be concerned that that's originating maybe from some kind of accident that could put a liability insurance as the primary, such as an auto insurance or a third-party liability insurance or work comp, for example. So sometimes if things get billed to the health insurance, that payer will put a hold on it, and they're asking the patient to document for their purposes information to support the notion that that particular payer is indeed the primary, has primary responsibility for that claim. So that's the number. That's one reason for the denials. The other is the request, and this is the number one reason, especially in specialty practices or in practices where there's procedures being performed or even diagnostics. There's a request for the medical record. They want to make sure the medical record supports what was done. Here, in resolving this issue, what we see a lot of times is that all we simply do is give documentation that the procedure happened, right? That's not necessarily going to be sufficient to get it paid. There's a mistake there oftentimes when people feel like, oh, all I have to do is send proof that we did the procedure and then they'll pay it. For many cases, and especially when you're doing procedures, they need more than the fact that you did it. So, of course, the op note or the procedure note, the diagnostic report are important, but also any background that you can provide as well, such as the last HMP or any office visit notes that indicate why that procedure might have been ordered or was necessary for patient care. All that goes to help round out a documentation request. So it's not always just proof the procedure was done. Sometimes that might be what they're looking for, but more often than that, it's the reason as to the documentation to support the reason the procedure was done. And additionally, not really reported here, but I can tell you that in our experience, between 5% and 10% of denials that we consider to be controllable are actually non-controllable because they're payer errors. Now, whether these are errors or whether they're denying on purpose, who's to say? I guess unless I worked at the insurance company or was in charge of designing their systems, I wouldn't know for sure. But oftentimes we might get a denial for timely filing, and we have proof that the claim was filed on time. We have to submit the proof and get the claim paid. Maybe it was denied for credentialing issues, and we have to have proof that the provider was indeed credentialed, and we have to ask the payer to update their records to reflect the correct credentialing date so that we can get that claim paid. Same thing with OS or even referrals or pre-certification. They may deny for services that don't require pre-certification. Just denied it, saying there's no auth on file. Well, there's no auth on file because there doesn't need to be one, and we have to appeal or submit for reprocessing that claim, talking to the provider rep, making sure they're aware that under the contract there's no pre-certification necessary for that claim. So in addition to non-controllable denials coming in related to documentation and coordination of benefits, some of those that we call controllable are also denied just because the payer has denied them. The advantage to the payer is if you don't have somebody working those denials, then they'll never have to pay for something they should have paid for. And by denying it in error, they've won and the practice is lost. So we have to be very vigilant in making sure that we're taking a look at every single denial and why it's there. And we can't assume that every denial is valid just because the payer says it is. So moving on to denial causes that are controllable, these are the ones that we see the most often. Billing issues, this is generally related to problems on the claim. It could be demographic issues. It could be issues with a referring provider that's needed and not there. Some claims, some payers have very specific requirements on the claim print library that a claim has to be populated in a very specific way in order for it to pass their hurdle of being clean. And if the library isn't correctly printing that claim or submitting that electronic claim with the proper documentation at every field, then there'll be a rejection for missing information on the claim itself. It's a pretty common reason. These are generally very non-specific when it comes to the reason code, and you actually have to go to the remark code to understand exactly what information is missing so that you can get a corrected claim out the door with the required information. Additionally, coding issues result in about 10% of the denials that we see across our database. Now, for every practice, it's different, right? Not every practice has the same distribution. This is a enterprise or a global distribution based on a combination of primary care, specialty care, therapy practices such as PT or occupational therapy, behavioral health practices, diagnostic practices such as imaging centers, surgical practices, you name it. So when we look at the whole spectrum of denials coming in across the board, this is the breakdown or distribution that we see for controllable reasons. But your practice distribution might look different than this based on, for example, if your primary care, probably you don't have a lot of authorization or pre-certification denials, right? Unless you're seeing HMO patients that are not assigned to the physician in your group that's seeing the patient. You may not have a lot of credentialing issues, especially if you have physicians that have been stable with the practice for a long time and all their credentialing is up to speed. Plan benefits more likely to be engaged when the denials when the practice is a specialty practice, but even in primary care. For example, we all know that Medicare allows for annual wellness visits, but only one within a 12-month period of time. And if you do bill a second one before that 12-month has expired, they're going to say that that it's denied because it's outside of the plan benefits. They do not allow two within a 12-month period. So, the processes we need to have in place when we see this type of denial is understanding what questions do we need to ask the patient as a part of, registration. If they've made an appointment for a physical, then we should be asking them, when's the last time you had a physical and which doctor provided that for you, because you don't necessarily know that they didn't have a physical from a provider that's outside of your network, right? If they're snowbirds and they're traveling to Florida or Arizona in the winter, maybe they saw a physician down there and had a physical, and you're not aware of it because it's not in your database. So plan benefits is another one that we have to watch. It's a little bit tougher to watch from a controllable perspective. And as I said on the last slide, on top of all these are these that deny, even though they shouldn't have been. We'll call them payer error. You can call them whatever they want, but generally, if you're not paying attention, it's going to result in lost revenue to the practice. So the other important piece is transparency and adjustments. So denials is important, but not all denials result in adjustments. A lot of times those denials can be reworked. And if you've got a good billing partner, they're going to give you insights not only into the denials, but into the adjustments so that you can understand when is it that we're adjusting off claims for reasons that we shouldn't have. So for our practices that we're taking a look at, about half of those adjustments are related to bad debt. These are non-contractual and non-insurance contractual related adjustments, by the way, or capitation related adjustments. Or sequestration related adjustments. These are the types of things that are generally considered controllable from an adjustment perspective. So after that, courtesy, the physician or the office decided to provide some courtesy. Timely filing, again, a big one. We have to track that back to the source. What's causing that? Is it the provider not turning in charges? Is it the front desk missing scanned documents to send? Is it the billing office that hasn't got those claims out in time? But understanding where that fail point is, correcting for it. And then pre-certification, that's ACCESe, that's referrals, having the necessary documentation that this procedure has been approved in advance. Credentialing denials, now this is an interesting one because practices know that their provider may not be credentialed for Blue Cross, but they're the only provider in the office that day. It's an urgent care center or somebody's covering in the office for a provider that is out. You have the choice, either see the patient or send them away. because the provider isn't credentialed. You probably don't want to send that patient away because they may not come back, right? They might find another provider and stick with that provider. So typically, we find practices will see that patient, even though the credentialing might not be in play yet. And there's got to be a write-off ultimately because as a part of the group, you're not allowed to bill the patient for that out of network. So we do see that happening quite often as well. Non-covered services, these could be Medicare services where there's no ABN on file. They could be coding mistakes, etc. Missing documentation, another coding issue related to inclusive and bundled. Of course, there's self-pay discounts, small balances, and bankruptcy, which we generally report on outside of bad debt just to see how that might be practiced, how that might be working within the community. So not only important to understand from a visibility perspective what's denying, but ultimately, what are we failing to get readjudicated with corrected claims and get paid? So having said this, when we look at the revenue cycle, we all know that denial prevention starts in patient access, right? So very strong registration and access processes, front-end processes, help reduce denials. And where we see denials for these types of reasons, OS, billing issues, generally demographic issues, coding, credentialing, eligibility, medical necessity, and even plan benefits, and sometimes time filing, we want to make sure that we can point you in the right direction to make those solutions. So things you can do at the point of pre-registration: verify the insurance, run eligibility checks before the visit, and do benefits checks, especially if you're performing services that you know might be limited under planned benefits, such as wellness exams or mammo exams or certain diagnostic testing that may only be covered for certain reasons or in certain situations. So that's all very important to make sure that prior to the service being rendered, the patient even showing up, you've got your ducks in a row and you know whether or not there's a good chance that that's going to result in payment. Making sure that if there are changes to the insurance plan, that you capture those as a part of pre-registration and or intake. So doing real-time eligibility, exchanges and unpaid premiums can lead to denials. What do we mean by that? You probably know that patients on the exchange programs, they have a certain period of time each month to pay for their premium. So they could have services delivered by your practice in July, not pay the July premium by the end of the month, and then have those services denied when they're billed, because even though they showed as eligible on the date the service was rendered, because the patient never paid for that premium, they ended up denying the service when the claim got to the payer, or even worse, they do a retraction because they paid you for that July 1st service date, and when the patient didn't pay their July premium by the end of the month, they then went ahead and retracted that money in August. So real challenge there with those exchange programs. Scheduling, require insurance, appropriate codes and authorizations. So if you know you're scheduling a patient for something that generally requires an auth for a patient with United HMO, make sure you're capturing that authorization information right then and there so that you can validate it with the primary care officer, with the payer if you need to. And then having an authorization team working with the back office, that's us, to verify that the authorization requirements and correct auth. Oftentimes we'll find an auth has been attached to a claim, but it's not the correct auth. It's not for the correct provider. It's not for the correct service. It's not for the correct date, or it's an expired auth. It's one that allowed for 15 therapy sessions, and this is session number 16. It's expired, right? Or it's expired by date. So not only having an auth number, but making sure that auth is valid for what's being billed. And then what we suggest is that when you do get auths yourself, or validate those with the payer, that you can record those calls or capture digital image of it if you actually got it online. Because sometimes even when you've got an auth and you have an auth number, the payers will deny for pre-cert, and you have to be able to prove that you have that auth number, and being able to do that, especially with a an image that you captured when you were obtaining that auth online is important. But not all of the denials are controlled at the front end. Your billing partner, your billing team plays an important part of that. So we support you in registration. We can be double checking and should be double checking the insurance card. If you're scanning the card along with the visit and it's an updated card, we can make sure the patient name is spelled right, exactly as it is on the card. We can make sure that the group number is correct, the policy number is correct, and make sure that, at least from a demographic perspective, that everything is correct so that you're not going to get rejections or denials for some error on that process. We can support with that. We can also support practices by assisting with pre-registration bulk eligibility, where we can run eligibility reports maybe 2 days before the patients come in, send you a list of everybody that failed eligibility, giving you some time to call those patients prior to the visit, make sure they're bringing in their insurance card. There is an add-on fee for that, but we do that for many practices because we find that that's cheaper for the practice than having their staff have to do those eligibilities on their own, or maybe forget it and have things fall through the cracks because of that. We also can support on the billing side with CCI edits, correct coding initiative edits, making sure that all the basics that are required for a particular CPT code, whether it's a diagnosis code or the correct sex of the patient, the correct age of the patient, modifiers, all those things are in line with what is expected to be for that particular service. We can also add specific audits. So CCI generally doesn't allow for LMRP, NCD, and LCD requirements for medical necessity. We can put audits in place to do that. We can also put audits in place for auths and referrals. So if it's not captured by the CCI, we've got additional add-on audits to make sure that, hey, United requires an authorization for an echo, United HMO maybe. This is a United HMO patient verified by the insurance card. There's an echo being billed. We need to make sure that we have an auth number that supports that. And then making sure that the claim library is configured properly, so we minimize or even eliminate as much as possible those denials for issues with the claim. Now, we all know that just as you understand the rules, the payers change them. So what you know about how to bill today for a particular payer, that could change October 1st, and we have to always keep up with those updates as they're published by the payers to make sure that we're updating properly and we keep your practice database up to speed on that. And we can also help with authorizations. Again, if there's an auth number before we drop the claim, verifying that it is an actual auth that is tied to that service for that provider, for those CPTs, and for those dates of service. So just doing a quick glance to make sure that the auth is relevant to what's being billed. And it's much better for us to actually find an issue now before the claim goes out the door, and then contact you and say, hey, we've got a problem with this auth, or we've got a problem with this referral, or there's some issue here on the demographics, giving you some opportunity before the claim goes out the door to make those corrections, update with the corrected auth, as opposed to waiting till a claim is out the door and maybe 30 days later or more denied, and now we may not be able to get an auth retrospectively, or a referral might be difficult to contact the patient to update demographics, even if there was a demographics issue. So we don't put it all on the front desk. We want to partner with you and support you so that even things that typically might be associated with front desk behaviors, we can help make sure that those are evidenced before those claims go out. Top 6 reasons for denials. Missing information, we've gone over that. Inaccurate information, we've discussed that as well. Just because a patient goes by Bubba doesn't mean that that's the name that the insurance knows him as. So we all might know Bubba Jones, but his real name is Poindexter. We have to make sure we have his real name on the demographics. I'm sure you all know that, but you might be surprised how many times that we have mistakes for that, or if there's a junior or a senior, making sure that those are properly identified on the patient name as well. The service is already adjudicated. This is generally with a bundling or an unbundling situation. We see that a lot, especially on procedures. Not covered by the payer. So we've talked a little bit about this. This is another big reason current benefits don't support that procedure, or they've exhausted their allowance for that. Our clients in Georgia that have Medicaid patients, they're limited to 10 visits a year for the Medicaid program. And it gets a little tough as you get towards the end of the year, because it's not 10 visits a year per provider or even per practice. So sometimes it might be the first time you see a patient in October, but it turns out they've had 10 visits with somebody else. And now you have to see that patient and you're not going to get paid because there was no pre-serve process or no process in place to verify that that's going to be an actual benefit. If it's not going to be covered, you can talk to the patient about how to pay for that. Limit for filing expired. We've talked about that. But it's important we realize as well there's two limits. Sometimes providers think of only one limit, which is the initial limit on the date of service to the clean claim date. Could be as low as 90 days, as much as 365, typically 90 to 180 for commercial payers. State Medicaids we see all over the board across the country. But there's a second one, and that's from the time it's denied until the time that the corrected claim goes out. That's generally much narrower and usually about 30 days. And some offices don't know that. They think that the only filing limit they have to be concerned about is the date of service to clean claim. No. If it was denied on day 30 and it's a 90-day initial timely filing window, you only have until day 60, day 30 from the denial date, in order to avoid a timely filing denial. So it really closes that window very quickly, even when you think you have a lot of time, because the denial occurred. The payer has a 30-day corrected claim denial process. And so sometimes when we sit on tasks or we're not up to speed on getting information back to the biller because we're busy and we have 100 other things to do, and oh, by the way, there's a lot of time yet, the patient was just seen 45 days ago. Not always the case, because that denial might have happened 15 days ago and the window's closing very rapidly to get that corrected claim back in. So we encourage all of our customers to make sure you're watching your tasks. Good best practices here is when you're tasked with some help to get us a corrected claim out the door, generally try and respond to that within 2-3 days max. And we make sure that we get that cash turned over to your practice as quickly as possible after that. And then again, we've spoken about prior auths and medical necessity. And these account for over 10% of denials, medical necessity being the diagnosis. And the most common thing we see here are denials for non-specific diagnoses. So our CCI edits, our audits should be watching for that. And if we see that there is only a non-specific diagnosis attached to a claim, again, we should put that claim on hold, ask you to talk to the doctor and find a better diagnosis for that particular visit. If so engaged, we do have certified coders. We can talk to practices about engaging one of our coders to mine or abstract the medical record to check for diagnoses that are in the medical record but not on the claim form. So we can help that way, but that's by special arrangement. We don't do that for every client. We have to make sure that you've approved that process, and we have a protocol that's in place that we both understand how we're going to do that and make sure we're doing it correctly and appropriately. But it is additional support that we can give to take some of that burden off of you guys when you get those types of rejections or denials. Finally, we're going to talk about our business intelligence. Now, some of you have been in on our Datalytics webinar. I'm not going to give you the full Datalytics webinar. I just want to show you the pieces of it that we use to support our denial management process and to give you all the information that you need. So let me go ahead and find it here, right here. So we're on Datalytics for a demo practice. Again, Some of you may know this is actually a live practice. This is live data. We have data in here through the 18th right now. This happens to be a dermatology practice. They've allowed us to share their data with the condition that we discrete their name, we redact their name, we redact the provider names, and we redact their location names. So having done that, we're free to share your denial. I want to focus on a couple of things here, or we're free to share their information. And I want to focus on a couple of cards here on the dashboard page that are related to either claim rejections or denials. First, we want to focus on the clearinghouse acceptance rate. For this practice, it's quite good, 99.7, and that's awesome, to be honest with you. But in fact, when claims do deny, the overwhelming reason for that is an eligibility issue, and those can be tracked back oftentimes to demographic issues, the name was spelled wrong, or when we put when the front desk put the insurance information into the patient account, maybe the card information was put in incorrectly. We just need to correct that and get it out the door. Sometimes the patient truly is not eligible. But in this practice, it's a really solid practice. If you have under 98% here, that's cause for concern. Generally 98% or above is pretty standard, but the closer you are to 100 means the less eligibility issues you're going to have that are causing claim rejections. And if I recall from the survey at the beginning of this session, Heather said that many of you feel that eligibility issues are the #1 reason for rejections and lost cash to your practice. Next, I want to focus you on the first pass claims paid rate. At this practice, not as good as we would like. We'd like it to be 98%. It's coming in at about 97.5. I can go to the bookmark just to take a look at, again, drill into the story, right? I want to be able to trend this and then understand the story. So going back to what we want business intelligence to show, it's not just the number, it's how do we get to that number. So here we are over time. This is over, I think, a 10-month period. I can just say, show me year to date. Here's where we're at year to date, just under 98%. So there's been some improvements, but we were up here and then we've fallen off. So I want to focus what's happening here in April and May, because here's the sad part about our job, right? Even when you have everything running great and we've got 99% of our claims being paid on the first pass, something happens, right? There's a break, there's a process fail, the payers change something and we have to respond to that. So I can contract this now to just the most recent 2 months just to see what that is, and that's only about 95%. So some work to do, always work to do, and we're always here to do that job. So now we're going to look at our actual denials page. Again, if you recall, I said best practices are going to be under 3% for their denial rate. Here, 1.4 this year, 1.6 last year, about 1% way back in 2018. So it moved from 1 to 1.6, and from 1.6, it's improving a little bit this year. Now, having said that, you know, it's still a good number, right? I mean, we see practices with 10, 12, 15% up here. So at 1.4 versus 1.6, that's not a huge problem, but we don't care if it's a small problem or a huge problem. We attack it the same way. We want to understand what the problem is and how can we improve it. Because when we look down here, we see that about 70% of these denials are for controllable reasons. So if I just click on that silo, here's my numbers. About 1.1% of charges are being denied for controllable reasons. And here's the big issues: billing, eligibility. Again, even though it cleared the clearinghouse, we're still getting eligibility denials after the fact from the payer itself. So just because we cleared the clearinghouse doesn't necessarily mean we're going to avoid an eligibility denial. So now, again, what's the story? I can drill through to the denial detail, and I can hone in on the last 2 months to make sure I'm looking at, you know, month to date through the 18th of July, we're way below where we ended up June. That's a good track, okay? If I look at the 6-month period, it's kind of been up and down, was in good place in May, kind of fell off in June. We want to get it low and stabilize it. That's our objective here, so we're always working to find out what's happening. So here I've got a table that tells me the #1 reason for rejections for the past month and a half has been pre-cert issues related to ACCESe, but there's been other reasons as well. I don't have to study this. I can take this table down here, export it. When I do, I'm going to get the data showing up in Excel. So here's the data that I just exported from our practice business intelligence from the Datalytics. And then I can summarize this and tell you as the practice administrator, the office manager, or the physician, here's what's happening right now in your practice over the past 45 days related to denials. Number one reason is for ACCESe. Okay, here's actually an office visit for a Cigna patient. And here, maximum benefit for this time period or occurrence has been reached. I don't know what that means. This could be one of those scenarios where I tell you about payers deny things in error. They should have paid, but they don't. And I think they hope, fingers crossed, that you're not going to do anything about it. You're just going to write it off or allow it to get to the timely filing window. Remember, many payers have a 30-day period for working this. And if you don't challenge it, they don't have to pay for it. So I would suspect there is a way to get this paid, even though it showed up as a denial with a 0 allowed. All right. And then we do have some procedures that were done without a pre-cert. So here we would go look and see, is there a pre-cert? And we failed to attach it at the point of the charge, but something failed here. We should have caught this before the claim went out. Some process failed. Maybe it failed at the front desk because they failed to get the auth for these two payers when these procedures were being done. Let's remind the office that they have to pay very close attention to these payers and the list of procedures that require pre-cert. Let's keep them constantly up to date. And then let's go back to our billing team and say, hey, if an auth indeed requires for these procedures, why did you let the claim out the door without putting it on hold and asking for the auth immediately? So we all have some work to do in order to make some improvements. So that's what we constantly have to do. Here's the issues related to eligibility, the issues related to billing. Here's some cultures that were done. They're not liking the place of service. I don't know. I can surmise maybe it's required to be in a CLIA certified lab and it's not a CLIA certified lab. Not sure. Not familiar with this coding. I'm sure the billing team knows. Or maybe it's just correcting the place of service and rebilling it. Maybe she does have one of her locations that is CLIA certified and they billed it from the wrong one. We've seen that happen. And then claim lacks information. What's missing? How do we get it on the corrected claim so the claim gets adjudicated? And how can we help stop this from happening in the future? Going on to the timely filing, we see 2 timely filing denials for dates of service from last November. All right, so somehow these 2 charges were missed. How were they missed? Why were they missed? What hung these up? Doing a forensic, right? The provider, didn't finish the chart, we missed them. Or these were add-on to the charts when the provider was doing a review, realized she missed these codes and put them in. Who knows how they got missed? Maybe they were sitting in a queue and just never got cleared. Maybe they were sitting with the billing office as an unbilled claim and no one was paying attention to that. So what our folks do is they'll do a forensic on this and find out. And probably more than likely, these were corrected claims or appealed claims, and they're going to have proof that timely filing was actually indeed occurred, because again, oftentimes we'll get denials when it's the payer error for that, and it's not a true denial. We always want to be working those. And then finally, some credentialing issues here associated with the mid-level provider. I happen to know this is a nurse practitioner in this group. Demo provider 1 is the provider, the physician. This is a mid-level. So we'd have to take a look at, does she, now this is weird to me as to why these are denying, but our team can work on getting these corrected as well. But the point here that I'm trying to illustrate, and I want to make sure you understand, is that with good business intelligence, with good insight, working with the right partner, with the right people who understand what you're doing day to day and who understand what you're dealing with in your office, right? You're not just billing all day long. You're seeing patients. You're taking phone calls. Who knows what you're doing? I mean, back in the day, we were looking for charts half the day when I was managing physician practices. So a good part of our time was spent just trying to find the chart, right? Those of you who've been around a long time probably remember those days. But there's always something, right? And you've got the phones ringing off the hook. You have patients that have questions and that you have to support the physician in 100 ways. So the last thing we want to be is the partner that puts it all on you. And so the denials are always just your fault. If you would do a better job, then we would have a better outcome. So we want to make sure you understand we are your partner. We're going to give you the information. We're going to guide you. We're going to show you where processes can be strengthened. And we're going to work with you constantly, because even when it looks like things are under control, they fall out of control again very easily. And then we go back to square one, regroup, figure out what happened, and get it adjudicated. So having said that, I'm going to skip through a few slides here. These here were just screen captures of the Datalytics, just so you know what I'm skipping through, just highlighting those pieces of the Datalytics that I was showing you live in the Datalytics and in Excel. This here is a new report that we've just started, which is our weekly operations report. We're actually looking here at the denials that came in the most recent week. So Datalytics here, this is a little bit better for Datalytics in that I'm always getting week to date or even daily information. So in the last week, the #1 reason for denials for this practice was actually credentialing, all right, followed by some coding issues and eligibility issues. So we're constantly working this funnel, focusing on the higher level ones, working ourselves down, and this funnel is never empty. There's always something that's denied for some reason, even if it's payer error. So we're constantly on top of it. So having said that, that's the end of my presentation. Hopefully you got some good information out of this. Heather's going to open it up to questions. I think hopefully you've been able to ask some questions. And so Heather, I'm going to stop sharing, turn it back to you, and allow you to go through the questions in the next few minutes we have here.
Awesome. Thank you so much, John. Before I get into the Q&A, I am going to just launch one quick final poll question for everybody. If you would just take a moment for that. And then for those of you who do not need to stick around or feel like you want to stick around for the Q&A, you are more than welcome to drop off. We do appreciate your time today. All right, thank you very much for those of you who did take time to answer the poll questions. I will say first, we did have a lot of you submit questions that were very practice specific using either the chat or the Q&A function. For those ones that are very specific to your particular practice, we are going to have your team address those directly with you. We did have a couple others that came in that were a little bit more broad, and I'm going to put those out there for everybody. The first of those is, does a denial ever equal that you will not ever get paid?
Okay, no. A denial, as I said before, sometimes is what we're classifying as a payer error. They just denied it. It was denied inappropriately. So we have to contact the payer, ask them to reprocess the claim and get it adjudicated correctly. So those are generally not hard to do, but the problem is they don't go away. No matter what you do, you've got payers that will just constantly, just fairly arbitrarily deny things. And oftentimes they're paid with corrected claims. So even if we're seeing that 15% of our charges are being denied, that's generally more a slowdown in cash, meaning cash is delayed because we have to wait for the initial adjudication period, maybe 30 days. Then we have to work that error, whatever that might be, the denial, fix the claim, and that might mean we need information from the office, we need a copy of the medical record, we need to support a modifier, whatever that might be, turn out the corrected claim, and then get paid on the second pass, and if not, then do a full appeal and try to get paid on the third appeal. So even in practices where we're seeing very high denial rates, 10, 15, as much as 20%, generally it's going to be more like 1 to 5% are adjusted off. So the best practices adjusted maybe 1% of those denials for controllable reasons become adjustments. The rest are able to convert to payment. Just takes a lot of extra work. And it takes about $25 per claim to rework. And that's not just on us, right? So you have to stop what you're doing. Your doctor has to stop what they're doing. They have to go back and visit a record to see if a modifier can be added or a diagnosis can be corrected or enhanced or whatever we need to make it a more specific diagnosis. All that takes time and money. So yeah, we can get them paid, but not without cost.
Okay, thank you, John. Another question that came in is, how and when are we notified of the denials that require our intervention?
All right, so again, I'm speaking to the broad group here, so we've got practices on different practice management systems. So I'm not sure I've got a one answer suits all here. But again, you can talk to your operations consultant and account manager about your specific software, but typically it's going to be done via a task. If we need your help on getting a corrected claim out the door, we will notify you. In most practice systems, there's a tasking element or there's a communication element within inside the software where we can tag it right to that encounter. So all you have to do is open up the task, take a look at the information in the encounter. Maybe we need a modifier, maybe we need a more specific diagnosis, and provide that information and turn the task back over to us. So that's the most common way. But again, there are ways that we can support you on those types of things as well. So talk to your ops consultant about maybe some better ways we can support you. So we know that the number one frustration any practice has in working with a billing company, us or anybody else, is the number of tasks, right? Generally, the tasks are associated with denials. So the more denials, the more tasks. So here's another reason to kind of clean this whole process up, to work with us to find the process weaknesses, shore them up, reduce the number of denials. But we can also help you in other ways as well, such as using our certified coders with the protocol that's been signed by your physician to make sure if we're going to abstract a record for a diagnosis or a modifier, that we've got permission to do that and we're doing that correctly. So other ways we can help you as well, where we don't need to engage you to get the corrected claim out the door. We can use our own resources quite appropriately for that.
Thank you, John. And the final question is, would bulk eligibility checks account for needed behavioral health prior authorizations as well?
Okay, say that again. I want to make sure I got it exactly right. One more time, Heather.
Would bulk eligibility checks account for needed behavioral health prior authorizations?
I'm going to admit I'm not an expert in the behavioral health and how that process works. So I'm going to have to go to my team that works in behavioral health and how that works, because I know you guys are pulling different insurance, right? Behavioral health isn't always handled under the medical insurance. Maybe it is, maybe it isn't. But you have to have a way of making sure that, that there is coverage for that. The patient has that insurance that they're giving. And that you understand what the plan benefits are. So the eligibility process should be able to cover all of that, right? Is this patient covered, and is the service we're intending on rendering a part of that coverage? So find out who asked that question, please, Heather. Let's go back to their director and let them know there's a specific question there I can't answer because I'm not an expert in mental health or behavioral health billing.
Absolutely. I do have the name and I will look up the email registration. So for Jessica, we will definitely reach back out to you after this with an answer to your question. At this point, I have addressed all of the ones that were more broad, and we do have a few people who we have communicated that we will be getting in touch with you directly for those very account-specific concerns and questions that have come up. So thank you again for your time today, and we look forward to seeing you again during our next presentation as part of the Practice Improvement webinar series.
Thanks, everyone.